Hello and welcome. Today, we're diving straight into a really challenging area of clinical practice, catheter-associated urinary tract infections, or CAUTIs. This is a field where you have to be incredibly precise because the line between a harmless bug just hanging out and a truly dangerous infection, well, it can be razor thin. And that really gets to the heart of the problem, doesn't it? The urinary catheter is one of the most common medical devices in the world, but it's also a superhighway for microbes. So the big question is, how do we as clinicians tell the difference between bacteria that are just there and an actual infection that's putting our patient in danger? So here's our game plan for tackling this. First, we'll define the problem. Then, we'll head to the lab to see how we gather evidence. We'll identify the usual microbial suspects, look at treatment and prevention, and then wrap it all up with a case study to put our knowledge to the test. All right, let's start with the absolute basics. Getting a handle on CAUTIs really boils down to one critical distinction: knowing the difference between a real infection and simple colonization. Everything else flows from this. So what's the official definition we're working with? A CUTI is a urinary tract infection that pops up in a patient who either has a catheter in place or, and this is key, it appears within 48 hours after the catheter comes out. Now, this right here is the cornerstone of CUTI management. On the left, we have asymptomatic bacteria. Think of it as colonization. The bacteria are there, you'll find them in the urine, but the patient feels fine. No symptoms. Honestly, this is almost universal in patients with long-term catheters, and we generally do not treat it. On the right, that's the real deal, a symptomatic UTI. You have the bacteria, plus the patient has clear signs of being sick from it. This is what we hunt for and what we treat. So what are those signs? Well, they tend to fall into two buckets. You've got your local symptoms, things like painful urination, or maybe the urine just looks cloudy or smells bad. But the real alarm bells are the systemic symptoms. We're talking fever, chills, flank pain, things that tell you the infection isn't just in the bladder anymore. It might be heading for the kidneys. That's pyelonephritis, and that demands action, fast. Okay, so you've got a patient with symptoms, and you suspect a real infection. It's time to turn to the lab. This is where we get the objective evidence we need to confirm what's going on and figure out how to fight it. And this process has to be absolutely meticulous. It all starts with a clean, sterile collection. Then, that sample needs to get to the lab and be processed quickly. You can't let it sit around. A gram stain gives us our first peek under the microscope, a clue about what we might be dealing with. From there, we plate it on different culture media to grow the bug, identify it, and see which antibiotics will actually work against it. And here is a piece of advice you should take to heart. This is a major clinical guideline. Why shouldn't you send the tip for culture? Simple. The tip is always going to be coated in a biofilm of bacteria. Culturing it doesn't tell you what's causing an infection inside the bladder. It just tells you what's living on the plastic. It's worse than useless, it's actively misleading. Now that we have a good, clean urine sample, we can start playing detective. Who are the likely culprits? And just as importantly, what kind of resistance are we up against these days? It's probably no surprise that E. coli is the main offender here, causing about 40% of these infections. But look at the rest of the rogues gallery. You've got Klebsiella, Enterococcus, and one to really watch out for, Pseudomonas aeruginosa, which loves to show up in patients with long-term catheters. And this number, this should get your attention. Almost 8% of E. coli found in these patients are ESBL producers. ESBL stands for extended spectrum beta-lactamase. Think of it as a defense shield that these bacteria carry, one that makes many of our best antibiotics, like penicillins and cephalosporins, completely useless. This is exactly why we can't just guess. We need the lab to guide our attack. So we have an infection, we've identified the bug, now what? It's time to launch the counteroffensive, and it has to be based on solid evidence. Okay, before we get into the heavy stuff, a quick one. Why did the bacteriologist break up with the virologist? Because he said she was too acellular and just couldn't replicate without him. All right, let's get back to the serious business of treatment. This table really lays out the strategy. And you can see right away it's not one size fits all. For a simple cystitis caused by common gut bacteria, a 5-day course of oral nitrofurantoin might do the trick. But look at pyelonephritis, the kidney infection. We're escalating to IV cefuroxime plus a hit of IV gentamicin. And if it's an enterococcus, the whole playbook changes again. It's all about tailoring the drug, the dose, and the duration to the specific situation. And remember, treatment is more than just picking a drug. If a patient is systemically unwell, we start with a broad empirical therapy, a combination like coamoxiclav and an aminoglycoside, to cover all our bases, including tricky bugs like Enterococcus and Pseudomonas. And this next point is absolutely crucial. If that catheter has been in for more than 2 weeks, you have to replace it. The old one is just a bacterial stronghold that will keep the infection going. Finally, we try to avoid routine antibiotic prophylaxis to prevent breeding more resistance. So far, we've been reactive. Now, let's talk about being proactive. How do we prevent these infections in the first place? And what do we do when we're dealing with special groups, like kids?
When we're dealing with superbugs like CPE or VRE, we have to bring out the big guns for infection control. Contact Isolation Plus means a private room, gowns, gloves, the whole shebang. For some organisms, we even add droplet precautions, which means wearing a surgical mask. Preventing the spread of these resistant bugs is every bit as important as treating the individual patient.
Now, kids are a whole different ballgame. In very young children, it can be really tough to tell if it's a simple bladder infection or a more serious kidney infection. Treatment for pyelonephritis is similar to adults, IV cefuroximine and gentamicin, but the dosing has to be calculated with extreme care using pediatric-specific formulas. Prophylaxis is also sometimes used in very specific cases, like for newborns with certain kidney issues. Okay, theory time is over. We've walked through the disease, the diagnostics, the bugs, and the treatments. Now let's see if we can apply all that to a realistic clinical case. So here's our scenario. You have a 72-year-old man. He's had a catheter in for 3 weeks, and now he's got a fever and flank pain. The culture results aren't back yet. Looking at those options, what's your first move? What's the right empirical choice here? Okay, let's think this through like a clinician. What are the key facts? He's systemically ill, fever and flank pain, and he's got a long-term catheter. That combination immediately tells us a few things. First, the risk of resistance to common antibiotics like Cipro is high. Second, our list of potential pathogens is wider now. We have to think about Enterococcus and Pseudomonas. This means a single antibiotic or monotherapy is probably not going to cut it. And that clinical reasoning leads us directly to the answer. It's D, coamoxiclav with an aminoglycoside. This combination gives us the heavy-duty, broad-spectrum coverage we need. It handles the usual suspects, but crucially, it also gives us a fighting chance against enterococci. The other options are simply too narrow for a high-risk situation like this one. Which brings us to our final lingering thought. We've laid out the best practices we have today, but we all know that microbes are constantly evolving, biofilms are getting tougher, and antibiotic resistance is growing. So, the real question we have to ask ourselves is, what's next? What innovations, from smarter catheter materials to new ways of busting biofilms, will we need to invent to protect our patients tomorrow? Thanks for joining me for this explainer.